Happy Friday. Happy 2/3 of the way through the semester. And welcome to the MAPS talk on health disparities and COVID-19. We want to thank the Great Valley Museum for hosting us on the YouTube page. If you scroll down, I would like to draw your attention to the Giving Day links. You can donate some money to the MAPS committee to help keep these talks going, help us invite other speakers from all over the country to give us science talks here in Modesto. Also, the Great Valley Museum has some projects that it's funding with the Giving Day, so I appreciate your generosity. Any small amount will help. Also, I wanted to announce that there are some Halloween videos on the Great Valley Museum YouTube page. If you click on the Great Valley Museum down below, this is the Great Valley Museum YouTube channel, you can see some Halloween videos from last year. The next MAPS talk we're going to have in just 2 weeks. Let's see what, get that. For Jennifer Danzy Kramer is going to be coming and talking about her primatology research that she's been doing in Africa and some of the work that she was doing with the communities, helping out the communities there through her research and conservation efforts. There's also some science colloquium talks coming up. This coming Wednesday, next week on Wednesday, there's going to be Tanya Barjeste talking about her nursing experiences in Zambia, serving those in need. Then November 18th, there's going to be a talk on California cow power. And December 2nd, so these are all Wednesday afternoon talks. December 2nd, there's going to be a NASA ambassador coming to talk to us. Here Comes the Sun are those talks that are coming up. So we have one 2 weeks from now on Friday, and then every other Wednesday for the rest of the semester. And I hope you're able to join us for some of those. Tonight, we are especially excited to have with us Chelsey Donohoo. She's originally from San Diego, California, and she received her bachelor's in molecular, cellular, and developmental biology from the University of California, Los Angeles. She then went for 2 years to Ethiopia with the Peace Corps as an HIV/AIDS health advisor, and then came back and received her master's in public health from the University of Arizona. And she was working in Arizona as an HIV public health educator, a case manager, and a maternal and child health epidemiologist. She's recently joined us here in Stanislaus County. She moved here in July and started a position as a chronic disease epidemiologist with the Stanislaus County Health Services Agency. So I would definitely like to welcome Chelsey Donohoo. Thank you for coming and talking with us tonight.
Yes, thank you all so much for having me. So today I was invited to discuss health disparities and COVID-19 and how that impacts the trends we're seeing within the community and how that more importantly impacts how we intervene or design interventions to help hopefully stop transmission of COVID-19 in our community. So as Linda mentioned, I'm a chronic disease epidemiologist by trade, but we all are doing slightly different roles with COVID. So under the COVID, I am managing the COVID-19 response. I'm managing all of the data that's coming in and trying to sort out case rates, track emerging trends, and identify new hotspots for COVID-19 and see what communities are being more impacted than others. So I thought I'd start out tonight's talk by discussing what is an epidemiologist. In case there's any future epidemiologists out in the crowd there, someone who's interested in this as a career. Essentially, I call us data divers. So we investigate the patterns and causes of disease and injury. So we look at a population and we say what's impacting them and what's killing them and what's causing harm to those populations. We're looking for those really big questions of what is going on, who is it impacting, and that hardest question, that third one, is always why is it happening to that population? And we're hoping to use these questions to really create a data-informed intervention to help reduce the mortality and morbidity trends. So there are a lot of different types of diseases, right? And so for some, it is very straight, those what, who, and why are very straightforward. So when we look at a case I had back when I was in Arizona, we had a couple people called into the health department who reported very severe vomiting and diarrhea. When we interviewed them and said, well, okay, where have you gone? Have you eaten somewhere? All of them had attended a wedding the day before. Well, when you hear those two magical words of vomiting and diarrhea and really bad, right, the first thing we always trigger is norovirus. So we immediately asked if we can get a sample from any of those people, and we're able to quickly identify what it was, and it was norovirus. We then looked at who, right, and it appeared to be people who attended this wedding. And when we looked at why, we went to the wedding, tested the water that they were using in the well there, and it was positive for norovirus. So then we take those three questions to get a pretty easy intervention of, we need to stop using this well water. So that's one aspect of what an epidemiologist can track and look at. But when we look at other diseases that impact our community, like cancer, those answers are less obvious. Cancer can be caused by genetics. It can be caused by behaviors like smoking and diet and exercise. It can be caused by exposure to UV radiation. It can even be caused by viruses like HPV. And so when we have a more complex disease that has more answers to why, it's going to take we have to take a little harder look into what's causing these trends. So at the very top of it, we have the expression of these diseases. So what it actually is. And that why, that bottom part of what's causing these trends and why it's impacting certain communities, is that bottom part of an iceberg, where we're really we can't really see it on the surface, but we know it's something that's leading to these disease trends that we've been seeing. So more often than not, when we start looking at that question of what is below the surface, what is it we can't see, we start looking for and trying to identify health disparities. And that is a situation, for that is when we're trying to identify what communities are being more adversely impacted by certain diseases. One of the first things we notice when we start looking just in general of who's being more impacted, who is experiencing worse health outcomes in our community, is when we simply just look at who's living longer. And when we look at the gap in life expectancy between the richest 1% in the U.S. and the poorest 1% in the U.S., that separation is 14.6 years. So for me, it's a pretty obvious statement when you might see it and say it at first. When you think of the impact of that, of the people who are the richest in the country live 15 years longer than the poorest people living in this country. And it's not just income. When we look at mortality rates based on urban and rural, we've seen much bigger strides in lowering mortality rates among people living in urban areas compared to rural areas. When we also stratify outcomes by looking by race and ethnicity, people living in the country, a really large impact, specifically when we're looking at maternal mortality rates in the U.S., where Black women in the United States, we've seen much bigger strides in lowering mortality rates among people living in urban areas compared to rural areas. My apologies, I think I had an audio breakup. When we compare Black women maternal mortality rates to white women maternal mortality rates in the United States, it's about 4 times higher. We also look at not just outcomes, but access, like the things that we know that make people healthier. We see that a larger percentage of Hispanic and Black residents in the United States, American Indian and Alaskan Native residents, don't see a doctor because the cost is too prohibitive. We also see when we think of things like that are linked to behaviors, like smoking, which we usually see as a behavior. When we stratify that by poverty level, we see adults living below poverty are much more likely to use cigarettes, cigars, and smokeless tobacco. So what does all this accumulate to? So we see these large disparities, whether it's in behaviors that are linked to health outcomes, or it's linked to the health outcomes themselves, like maternal mortality rates. And when we break down of what is the cause of this, we have a little bit that's related to genes and biology, so what you inherit. We have some that's linked to health behaviors, so things like diet, exercise, smoking. We have some based on the medical care someone receives. But that biggest chunk, that biggest piece of that puzzle are social and societal characteristics. And this is really, truly what's below the surface. It's the social determinants of health. And these are the factors that are responsible for a majority of health outcomes, particularly when we're looking at health outcomes within the United States. And that is the level of education, that's access to health care. So if someone, and that's not only the type of health care someone can receive, but it can be something as simple as, do you have health care? Do you have specialists in your community that you have access to? It's neighborhood and environment. So whether that is the level of pollution or toxins in your water or your air, it is also things like, do you have a neighborhood that's walkable? Do you have sidewalks? Do you have a neighborhood that's safe? Do you feel like you can walk around at night? When we look at things like physical activity, if people don't have a neighborhood and environment that are conducive for physical exercise, that's going to have an impact on their health. Social and community context is perhaps of these the hardest to quantify, but we know this has a large impact on someone's health. This includes things like discrimination, racism, prejudice, things that have an adverse impact on someone's health due to the stressors and the hardships that these cause. The last one, which perhaps is the one most familiar with, is economic stability. So the more income someone has, if they're unemployed, or if they're unemployed versus employed, we see a vast difference in health outcomes that are impacting that population. So when we look at these social determinants of health, one way I've found that kind of gives the overall arching what these social determinants equal to is the level of stress it can bring in a person's life. We're all very familiar with stress. We know its effects, right? It can cause fatigue. It can make it harder to think through or process things. It can cause depression, anxiety. It's also linked to things like chronic illness. It's linked to a depressed immune system. So you'll notice maybe during finals time or when you're having a lot of stress or pressure, you're more likely to be sick. And it's also linked to poor mental health. So cortisol is that magic chemical that we think of when we think of stress, right? It's released as a part of the stress response, and it's been linked to a lot of things I just mentioned when we're talking about stress impact on the body. The link in the immune system, heart disease, high blood pressure, nervous system problems, digestive issues, anxiety, lack of sleep. Cortisol has been linked to all of these. Now, when we pull out stress, so we have the stressors of a tough exam, we have the stressors of having to give a presentation, we have the stressors of the everyday problems we encounter in life. But we also have those larger chronic stressors. So things like I mentioned before when we're talking about those social determinants of health. Living in high areas of high crime, experiencing poverty, not knowing if you're going to be able to pay your rent or not. Having a lot of exposure and experience to racism and discrimination. Those things are larger stressors. And we found that those stressors have that same impact that we talk about when we have those small stressors, except it's over a prolonged amount of time, which creates kind of a chain event. So when we think about it as everyone has a cup and that cup can be filled with stress. So if you are starting your day and you have a steady job, you have access to resources, you don't have a lot of extra stressors or those large chronic stresses on you, you have a lot of room to fill up that cup of stress. So if I have, if I'm starting with a low level of stress, I can, I think I may have lost you.
Hello, everyone. Sorry, it looks like we lost connection with the speaker a little bit. We might have some Wi-Fi issues, so I'll see if I can get her back. I don't know if the Great Valley Museum can pause the YouTube temporarily while we have her try to connect again.
I'm still able to hear you all if you're able to hear me.
All right, well, I can try to get the slides up then, because I have another copy of them, and then maybe you can just sort of narrate them. So let me just get that started. In the meantime, if anyone has come up with a question from what you've seen so far, don't forget to put that in the chat.
Thank you all. Oh, the joys of working in during COVID time.
I should have had PowerPoint already up and running. We'll know for next time. All right. Let's find where we were. We were talking about glasses half full and half empty here.
Stressors.
Yeah. Can I start from here?
Thank you. And again, my apologies for the internet disruption.
'Tis the way the world works in COVID times.
Yeah. All right, do you need me to do the next slide here?
Yeah, yes, please.
Okay.
Are we seeing that cup of childhood trauma?
Okay, let's go to the childhood's trauma.
And I'll follow along, hopefully. Thank you all again for helping me navigate through.
Okay. All right, so Chelsey, are you still able to hear us?
Yes, I am.
Okay. So do you need me to go ahead some more?
Nope, this is perfect.
Okay.
So when we have someone who starts out with, when we look at the social determinants of health, with kind of that empty cup, so they don't have a lot of those chronic stressors. But then we add something like they have a history of childhood trauma. That chronic stress and growing up under those chronic stressful conditions results in someone already approaching a situation with kind of that stress load already half filled. Next slide. And then when you add on another economic stressor on top of that, like maybe you lost your job and now you don't know how you're going to pay for your rent. You then fill that cup up with stress a little bit more. Next slide. Which means you can reach the capacity where you can no longer handle the amount of stress and chronic stress that you're under. So the best way, and I think the best lesson I had to learn what this looks like and how this truly impacts health outcomes when I was working as a HIV case manager. And when I first started that position, I would have clients who we were trying to get onto treatment. We were trying to make sure they could see a doctor. We were trying to make sure they were in a place if their medicine required food. We had food that we could provide. But more often than not, we would encounter a lot of barriers with trying to get patients to practice medication adherence and to go to the doctor to do those necessary steps needed to stay healthy. In the beginning, before I knew anything, I had a hard time understanding what was creating this barrier. But when I came to learn and approach it as the clients I was seeing were coming to me with their cups already full. They had periods of trauma within their life. They had economic instability. They lived in areas that weren't safe. They were living with a chronic condition that's related to stigma and the stress of that. And so any small task or any additional stressor made it so that cup overflowed that much faster. Next slide. And unfortunately, with stress, it's not all about going back to empty. So if someone is living under a long, extended period of chronic stress, we find that they never go back quite to that empty cup. That it creates a new level in which they are more likely to be incapacitated by different stressors. And remember, these stressors are what are linked to these health outcomes, right? Those chronic illnesses, depressed immune system, and other poor health outcomes. And so we have the social determinants of health have those really immediate impacts of if I can't afford my medicine, I can't get my medicine. But what if it's also compounded by I've experienced such trauma and I've been under such extended chronic stress that it's not just about getting my medicine. I'm more prone to getting sick because I'm living under these chronic stressors. And so I like to start out my discussion about health disparities because I think a lot of times that goes just to resources. It goes to we need to provide more education. We need to provide, if we just provide the medicine, if we just provide this resource, it's going to result in lack of disparity anymore. But it really is way below that surface. We have a much larger issue of it not just being an immediate resource, but the result of years of trauma and chronic stress that has resulted in someone not only not able to treat a sickness, but more likely to be sick and get sick and have poor health outcomes. Next slide. So I wanted to pause there because the next section kind of goes into COVID and those patterns. So I wanted to give the opportunity, though, before we get there to ask if anyone had any questions about what we've discussed so far.
So there's been some questions in the chat. One of the questions in the chat was, do people living in the countryside with less internet have less stress? Do you know of any study or data supporting that?
So it's actually shown that people in rural communities have higher stressors. Now, the idea of communication is a really interesting one of having less access to internet, creating less stress. But more often than not, we see those worse health outcomes for rural people or people living in rural areas because they have less access to resources in general. So to go to the doctor, you might have to drive an hour. To go to a specialist, you might have to drive 4 hours. If you live in a rural area and you lose your position, you have to go much further to find another one. We also see higher rates of poverty in rural areas, which is another determinant that could be leading to those worse health outcomes. And the other thing, especially when we think of internet, we use it a lot. Like there is this idea of it creating stress, but things like internet also creates an incredible amount of access. So not having access to the internet also puts someone at a disadvantage because they're not able to access the same resources that someone who does.
Thank you. And then we have kind of a two-part question, it looks like. Stress appears to be defined in an empirically measurable way as when a human has X, Y, or Z levels of cortisol and other physiological but measurable indicators. Is that correct? And relatedly, are scientists able to say, for instance, that person A has 2.7 times as much stress as person B, or is it that precise, or is it a more vague definition?
There are studies that do look at levels of cortisol, and actually an interesting thing happens once you're under longer periods of stress. Actually, your response, your body's ability to respond and handle stress, actually results in a reduction of cortisol because you're no longer able to control that stress response. But they use that to measure and compare people's health outcomes to see if that's what's impacting it. But it's nuanced, right? Some people have and respond differently. There's also something that I didn't mention in this, which is like resilience. So some people who are living under a large amount of stress have had the same amount of trauma or exposures. There are some people in some communities that have what they call community resilience. So it's the ability to recover from those high levels of chronic stress. And that throws a little wrench into the equation. It makes it even harder to measure. So it's not a good answer. There are great studies out there that point to it. When you look at, I recommend looking at, I didn't mention it in this talk, but looking at studies around historical trauma and how they measure the passing down of people who have gone through incredible stress and trauma. There are some really great quantitative studies, but as far as saying this person has 2 times more, we're not quite there yet.
Great. And then another kind of two-parter, it's putting two questions together. Is there a counteractive measure to an increase in cortisol levels? For example, the use of things like yoga and mindfulness to reduce the amount of cortisol?
That is a great question. And yes, both of those things have been linked to that stress reduction. So when we're able to keep those levels of stress down or have some relief, give the brain some relief, we are able to see us not reach that overflowing level as quickly. We're able to take some of that water out of that cup, right? And so things like practicing mindfulness and meditation and even things like therapy, but also things like community gatherings, which sounds weird in times of COVID, but having a community or someone to talk to or feeling a part of something, things like that that reduce stress are shown to have that positive impact.
All right. And then I was just going to do one last question that combines some of the others. Is there any level of stress that is considered good stress to move our bodies forward?
So when we look at like what stress is, it goes back to our fight or flight response. So the purpose of stress is to get our body to respond and act quickly. So stress in itself is not bad. It's the more chronic, prolonged stress that creates, has a result of more of this chronic illness. I have not seen any studies that show someone who has no stress is more or less healthy or active. So that's a good question. I haven't seen any studies, but small doses of stress are normal in our body's normal responses.
All right, I think that maybe we should move on to the next part of the talk.
Go to the next slide. So, many of you may recognize this is Stanislaus County. And when we're looking at health outcomes within our county, one of the things I wanted to start with is looking at through the lens of California's Healthy Places Index. This is a very easy website to access. I recommend everyone take a look at it. And essentially what it does is it's stratified and broken up all of California into 4 quartiles. So people with the worst healthy places score, which is linked to things like those social determinants of health we talked about. So high rates of poverty, high rates of chronic illness, lack of access to healthcare. And it also looks at it of areas that have more access and less poverty and more access to resources. So if you look at Stanislaus County as a whole, you can see a lot of our quartiles, and this is how they do how they look at a specific section is by census tract. You can see a majority of our census tracts are blue, which means we are scoring less, we are less healthy than about 50% of other census tracts in California, is what that blue means. Next slide. So we dive a little deeper and we look at, let's just compare our census tracts to our census tract. This area is our lowest scoring census tract in Stanislaus County. When we look at the characteristics, close to 40% are living below poverty. More than half do not have a high school degree. And when we look at how this is stratified by race and ethnicity, 81% of the population in the census tract are Hispanic, and 30% were born outside of the United States. So this is going to feed into, perhaps those social determinants, the lack of resources, but also how resources look like in our, how resources are distributed, the wrong word, how resources are allocated in the U.S. So we tend to see in Stanislaus County, higher rates of poverty among our Hispanic residents as compared to our white residents. Next slide. So this represents our our highest scoring quartile. When you look at this, about 8%, 8.6% are living below poverty. So that's much different than our lowest quartile. Only 6% of these residents have less than a high school degree. 27.3% of the population has Hispanic, and 20.8% were born outside of the United States. And so what I really want to draw in this is even with within our own county, right? These are small little pockets of our community. We see very vast differences. When we look at this as compared to health outcomes, next slide, we start seeing a very real impact on health outcomes and how it is being expressed among these communities. So if we look at pedestrian injuries, they have one of the highest rates of pedestrian injuries in California. So it is, on average, this census tract has higher rates of pedestrian injuries than 93% of the census tracts in all of California. When we compare that to our highest scoring census tract, we see that pedestrian injuries are higher than only around 40% of census tracts in California. Next slide. We also see this when we look at other factors influencing and perhaps impacting the communities that live in these areas. We look at the percentage of physically or mentally disabled residents living in these census tracts. We see a much lower rate in our higher scoring census tract compared to our lower scoring census tract. Next slide. Along the same line, when we look at heart attack, ER admissions, right? So those cardiovascular impacts, we see, although in this case, our highest scoring census tract isn't doing great, but it is certainly doing better than our lowest census tract, where only 1% of California census tracts have a higher rate of heart attack ER emergency admissions in all of California, compared to our highest census tract that's around 30%. So we see, even within our small range of our county, we see a really big difference between the socioeconomic factors of the residents who live here and the health outcomes that are impacting these residents that live here. Next slide. Unfortunately, we're seeing the same thing play out when it comes to COVID-19 and how it is impacting our community, but as well as the communities across the United States. When we look at hospitalization rates by race and ethnicity, we see it highest among our non-Hispanic American Indian Alaska Native residents, our non-Hispanic Black residents, and our Hispanic and Latino residents. Next slide. This also translates to when we look at who COVID-19 is killing. We see when we adjust for the distribution of COVID-19 deaths compared to the population, we see is the highest among our Hispanic residents in California. And whenever we look at data like this, we always want to think, well, we know COVID-19 has worse outcomes for people over the age of 65. So maybe perhaps our Hispanic population in California just happens to be older. So we always want to standardize it for age to make sure that that's not what's driving this impact. But when we standardize it, we actually see the impact even a little more severely. So we can see the deaths are impacting Hispanic residents in California at a much greater rate than non-Hispanic white residents. Next slide. So when we look at how this plays out in our county, in Stanislaus County, we first look at case rates. So this is looking at the number of COVID-19 cases per the population of these residents by race and ethnicity. And we see the highest case rate starting in May has been among our Hispanic residents. When we look at how this has trended across the epidemic, there was that large spike drove across all races and ethnicities that we all saw and experienced in July, but more adversely impacted our Hispanic residents. And we think of case rates, right? This isn't health outcomes, this isn't hospitalizations, this isn't deaths. We think of who is more likely to contract, or we see positive results in a certain community. The first thing we all think of is behaviors, right? Is the behavior driving this? And so when we look at the socioeconomic characteristics of these communities, we find that in Stanislaus County, Hispanic residents are more likely to be essential workers. So people that can't stay home, that don't have the option of when they're sick to not go to work, don't have sick time that affords them the ability to stay home and isolate when it's recommended. They don't have the same resources that other residents have to perhaps do the things that help mitigate COVID-19 spread. Stay home when you're sick, social distance, and make sure you're able to isolate as best you can when contracting COVID-19 and when you have a family member, someone around you who contracts COVID-19. So it's always important when you look at rates like this to think about it through that social determinants of health lens, because that's going to really feed into what is driving the rates and what's driving the spread of the disease in the community. Next slide. So when we take a closer look at this and we start looking at deaths in the community, so this graph depicts all deaths in Stanislaus County of all causes. So we didn't look at, this is all cause from any type of death. We can see something, a dangerous trend started in June. So that top black, the bottom green dashed line you see there is the 5-year average. So that's by month, the average number of deaths we typically see. That black line you see there is 2 standard deviations above that average, that historical mean. And so we set that as our historical limit. And it tells us if we go above that historical limit and if we go above it consistently, something is happening. And starting in June, July, August, September, October, our deaths are still being reported, so we can't finalize that yet. We have seen an aberrant amount of deaths among Stanislaus County residents. And when we look, is COVID-19 the only cause? We can see that, yeah, it's that green bar. We can see, yes, that's definitely driving it, right? That's definitely contributing to a proportion of it, but it's not really accounting for all of it. So it indicates there's something else that's potentially happening. Next slide. And so when we separate out this by race and ethnicity, in Stanislaus County, we have we typically are only able to look at health trends at a larger scale at this level. We divide it into non-Hispanic white residents and Hispanic residents because the populations are large enough. When we're trying to do aberrations for other populations, the population sizes are too small, so it creates some variability in the numbers. But when we draw out among these two populations, we see actually starting back in March, we started to see aberration of deaths among our Hispanic residents, long before we had any COVID-19 deaths recorded. And unfortunately, that trend, we saw it equally in that July, August, September when we had that surge of COVID-19 cases. But among our Hispanic residents, we saw an aberration in March, again in April, again in May, again in June, again in July, again in August, and again in September. So you really see how COVID-19, that national trend we looked at earlier, is being reflected and mimicked in our community. Unfortunately, we're seeing this disparity really play out in COVID-19 deaths and spread within Stanislaus. Next slide. So when we look, we try to look at other factors that are potentially driving or are characterizing our case rates within Stanislaus County. There are some things that we can't track by cases. So race, ethnicity, and age are very stabilized factors we can account for because that's usually reported to us when we receive a positive lab. But these other things on this that are those social determinants of health drivers, the percent of population living in poverty, the household size, education, where they, like the census tract in which they live, where they're from. All of these things are a little harder. So what we do is we look at hotspots within the community. So this represents the top 5 census tracts with the highest COVID-19 case rates. And we see of those census tracts, on average, they have higher levels of poverty. The household size is slightly larger. We see a larger percentage of the population with less than a high school degree. On average, they are living within those lower HPI census tracts, so those lower scored tracts. And we see a higher percent of the population that was born outside of the United States. So all of those chronic social determinants of health that we see have a negative impact on health outcomes, we see are reflected in the COVID-19 transmission within Stanislaus. Next slide. So that brings us to this question of what to do. So this is maybe an image some of you have seen before, but this is when we look at how we allocate and how we respond to large health crises, we have something which is an equal allocation of resources. That's health equality. That's us all having the same resources and having, in order to address health disparities. But what we've seen is, right, it's not just about access, not just about the resource themselves. There are some populations who are starting with a step back from other populations. They're starting with less resources. So just by giving this one resource, it's not going to create an equal response. So the picture to the right is how do we not create necessarily equality, but health equity? So how do we make sure populations each have the same chance to have better and improved health outcomes? Next slide. So this might be something you're all familiar with. This is the COVID-19, the blueprint for a safer, California's blueprint for a safer economy, the COVID-19 tier ranking system that looks at if we're in widespread, substantial, moderate levels of COVID-19 transmission in the community. Stanislaus County is currently in the red, we're at substantial. So it looks at things like case rate, which is just the average number of daily cases we receive in a day. And so obviously higher case rates means higher levels of COVID-19 transmission. It looks at things like positivity rates. So of the people we are testing, what percentage are positive? That's also going to tell us the level of spread in the community. And they recently added on this a new measure to this, which is the health equity quartile. Let's talk a little bit about that. Next slide. So what it does is it looks at Stanislaus County across case rates, and it looks at testing positivity across Stanislaus County by those HPI census tracts. So it targets out and pulls out those census tracts that have our lowest HPI score, so that bottom 25% census tracts within Stanislaus County. And this metric asks us, okay, even if the county as a whole is doing well, in order to advance or in order to be moved down a tier, we have to ensure that the testing positivity in these quartiles are low enough to get us to the next tier. In short, it's making sure we're not concentrating in our areas and we're not seeing just a decrease in the areas of communities that have the most health resources and the ability to, or who are less likely to have these adverse health outcomes, making sure our efforts are concentrated on these areas that have more adverse health outcomes, have higher rates of COVID-19, and less ability and resources in the community to do the health practices that are being recommended to prevent COVID-19 transmission. And so when we talk about interventions that are designed with the social determinants in mind, are designed to create interventions that are aimed at health equity, this is one of the measures we can take. And so within Stanislaus County, we are meeting that health equity metric. As a county, we have made sure that when we're targeting testing and we're targeting interventions, we're making sure to go to areas that have less access to testing, have less access to the ability, with the ability to prevent COVID-19 transmission, less ability to isolate. We've made a conscious effort to focus on providing testing resources and intervention resources to these communities, because we know this is where the case rates are highest. And we know this is where people are most likely to die from COVID-19. So, next slide. So that's where I wanted to end, just to give time for some questions, if there are any questions around health disparities and what we're seeing in Stanislaus County. But thank you very much for the opportunity to speak. I've and enjoyed being able to present this data.
Thank you very much. Okay, so some questions from the gallery. The first one says, when it states Hispanic population, is that making any difference between Hispanic US-born citizens and non-documented Hispanic residents? And this asker asks because they would like to know if it has to do with race or if it's really about not having access to resources such as health insurance through employers that a citizen might have.
Yeah, that's a great question, and definitely something when we're looking at access to resource, being undocumented versus being undocumented is something that puts someone at a higher risk for adverse health outcomes. For us, we're unable to collect that data simply because when we're asking investigation questions, we want to be able to engage the populations we're working with, and so we don't collect that information. We're more focused on providing that education and intervention. So definitely a great question, but not data we collect. So I don't have access to that.
Okay, and then the next question, why are the deaths within the white population higher than normal, but with the lower numbers attributed to COVID? Is it possible people are dying of COVID without being tested?
So that's a really great question as well. So when we break down the data, because of course, one of the things an epidemiologist always does is how small can I get this data segmented to figure out what is going on with this trend? And so when we separate it out by age, we see that's potentially what's at play. Is the average age of someone who is infected, the case rate by age and race and ethnicity, we see that non-Hispanic white residents tend to be a little older. And we know older residents are more likely to have worse health impacts with COVID-19. That is combined with, in general, we see a higher, the age of non-Hispanic white residents in general across Stanislaus County is older. And so when we look at things, so the only cause we can see are things that are kind of linked to aging diseases, so degenerative nervous system diseases, cardiovascular diseases. And so the thought, and this will require more data, is potentially this is linked to older community members having less access to healthcare during a time when our healthcare systems are pushed to the brink by levels of COVID-19 transmission. That's one thought just based on what the cause is, but of course we need a lot more data to really dive into that and answer that completely.
Great, thank you. And then why are some of the daily cases listed as probable? Is this due to testing platform differences in sensitivity?
So probable, I think this refers to what is on our dashboard. So we have how a confirmed case is defined as something that has a confirmatory PCR test, positive test. So something, a molecular amplification test. And so that, by the case definition, is a confirmed case, and what we count as a confirmed case and what CDPH uses to calculate our rate. But a molecular test is not the only type of test that can look for COVID-19. You might have heard of the antibody test, right? But antibody tests just show you had an infection. They don't show an active infection. So this isn't something that's really being tracked to show transmission rate. There is another test, though, called an antigen test. And this test does not amplify the virus, but it looks basically for surface level proteins on the virus is a short way to say it. Their molecular biologists could say it better than I. And what it does is it is able to detect COVID-19 at a high enough specificity, which means low false positive rates, where clinically they're telling providers to treat a positive COVID-19 antigen test as a positive test. So a clinician can treat it as a positive, unless the symptoms don't match up. For our investigation purposes, since it's not necessarily recommended for a person to get a confirmatory PCR, we investigate them like they are confirmed cases. But it is a less sensitive test, and we also, so there's a higher rate of false negatives because it can't detect as low levels of viral levels as the confirmatory test. And it isn't like the PCR is the gold standard test. And so it has to do mostly with the type of test being done. We wanted to put it on our dashboard and let people know about it, though, because it is something we're investigating. And it does, because they are treated like positive cases, speak to levels of transmission within the community. So a long way to say it's not being used to calculate our case rates, but the test is good enough where we treat a positive as a positive.
So a follow-up to that I'm just thinking of right now, if they are not treated as actual positive cases, and with the move to more antigen-based testing rather than PCR-based testing as we stretch our limits, will that not artificially keep our case numbers lower than what they ought to be reported?
Yeah, and so we treat them as positive, but you mean it's not using to calculate them for our tier levels. That is something, as antigen tests are being more utilized in the community, especially with the development of the rapid antigen test where people can get results in 15 minutes. And this is definitely something we are starting to look at. I think the issue they run into is with case rate, it might be a little easier because we can just put the probables in with the confirmed. For testing positivity, however, we don't have a denominator for those antigen tests. So for all PCR tests, we are getting reports, same consistency of those negative and positive tests. So we can calculate the testing positivity. Versus for antigens, we have a harder time doing that because it skews the testing positivity to be higher because we don't have that same denominator. So right now, CDPH, I think, is working on developing how do we look at probables, and how do we, if the number of probable cases are starting to rise to a higher level that they would impact case rates, how can that be factored into the tier system? So this whole COVID-19 response has been about fluidity and adapting as more tools and more information comes out. This is definitely one of the next steps that we are working to adapt to.
Okay, and then why is positivity rate a factor in severity of the pandemic? It seems like it can vary quite a bit just by well, that's kind of the same. But if we have more people who are less likely to test positive and they are being tested as well, doesn't that also artificially bring our case rate potentially down by encouraging people who would not normally be tested to actually get tested?
So that's how we look at the two factors. So one, we want to make sure, so let's say our case rates are low, but our testing positivity is really high. That's telling us we're only testing people who we have a high suspicion of COVID-19. So in the beginning, that's a lot of what we were seeing because we had limited access to testing resources. So we were only testing people who essentially were hospitalized, right? Or we needed to get a test. So that shows lack of testing resources, which shows a lack of ability to respond and adequately detect the virus in the community. Case rate, though, having a high case rate and a low testing positivity rate could denote what you're saying, right? Which is we're testing the wrong people. We're not doing enough targeted testing towards areas that could have high rates of COVID-19. So that's kind of why we look at these two factors together. So we can kind of get a better idea of the picture of both the number of cases we're seeing, but also compared to the amount of testing that's being done in the community and what those positive tests of the total amount of tests we are. And the idea around increasing and encouraging testing is we want, the more people know if they're positive or not, the less transmission we're going to see. So it's better to, like, increase testing is a pretty effective public health intervention, because when someone knows they're sick, they're more likely to adapt those recommended behaviors.
Okay, I see. And has there been any data collected on the homeless population in this county?
Yeah, so there's been some data. It is a data field we have. It is filled out inconsistently, so that's why I don't have any data that's on here, because when we collect information about a case, typically it is because we've interviewed the case. And our homeless population is hard to be able to interview due to lack of access to like a phone, a stable place to call, those factors that really like skew us against the ability to investigate all of these cases. Now, what we do find is if there is like an outbreak at a shelter, we are a little more easily able to identify these populations. Stanislaus County, we haven't seen, mostly due to lack of number of cases among this population, whether that is due to us not having the information or just simply lack of the numbers. We're not seeing a large difference, but there have been other states and other counties that have seen higher impact among this population and worse health outcomes among this population, as we see from a lot of health outcomes when we're working within this population.
Okay, and some more data. There's lots of data questions. As somebody from a large Hispanic family, what role do at-home family gatherings have in community spread versus just people going to work in the public, taking precautions like mask wearing? Do you have data on that?
Yeah, it's interesting when we look at transmission, like the type of transmission. Again, we are only able to identify that by what cases tell us. The number one right now mode of transmission or type of where the transmission source was household contact. And so that is the number one we're seeing, but it isn't very stratified by race or ethnicity. It is common across all races and ethnicity. Second most common is workplace contact, and third is the social gathering, so community, so small gathering outside the home or within the home with non-household contacts. But we haven't really seen a difference when we stratify by race or ethnicity.
Okay, and then a couple more if you have time. These two next ones I think are related, kind of, sort of. One, is there a community-wide plan that is in the pipework as far as testing kids as a plan of getting them back into classrooms?
I am not part of the testing strategy development when it comes to schools or getting kids back in the classroom. So I can't really speak to what strategy would be developed there. In general, across the county, we are working to increase the amount of testing that is done in the community, because that is one of the factors that adjusts our case rate. So makes the CDPH account for the amount of testing being done in the community by adjusting our case rate based on our testing rate. So every week when they look at our tier, they also look at how our testing rate is compared to all of California. And if we are below the state median for testing, they bump up our case rate. They adjust our case rate to be higher. If we are above the state median for testing, they drop our case rate down. And so that's why we're really not just testing for specific populations, but really encouraging everyone to try to access these testing resources, especially if you're symptomatic, had a potential exposure, and have been in a situation where you might have been exposed to COVID-19. Because again, knowing if you're positive is a really effective way of preventing future transmission.
Great, thank you. And then just one more, since it's quite late. Are you able to estimate how many people have contracted COVID in the community that have maybe gone unreported because they never got tested?
Yeah, this is a really hard one, especially with COVID-19, because it's such a new virus. Right now, I don't have, within Stanislaus County, we don't have good data that can really point to how many unknown infections are going within the community. Hopefully, retrospectively, we can get a better idea of what that number is. Essentially, one of the easiest ways to do it is we take a look at a case and we see, okay, did this case have a known contact with someone? And if they have a known contact, we're really able to draw that line from person to person, transmission to transmission. But if we have a large amount of cases that don't have a known contact, that don't have a known mode of transmission, that creates more questions. That creates, one, are they out and about and exposed and being constantly exposed and they might not have known it? Or were they being exposed by someone who's either asymptomatic or had minimal symptoms, or was symptomatic and simply wasn't masked and they were exposed that way? But because we're still trying to get a grasp of like what community spread looks like, and honestly what transmission looks like with COVID-19, we don't have good estimates of that right now. But it's a really good question, and one I'm really looking forward to diving into in the future.
All right, well, thank you so much. Thank you everyone who attended and all the great questions that we got in the chat. Thank you for all of those. I apologize, there were probably a couple that we didn't get to. We tried to get to quite a few. And I would like to definitely thank Chelsey Donohoo again for all the great information and for all the help answering these questions that we've had. And I hope that people join us for future talks. And don't forget to check out the other things on the Great Valley Museum YouTube site, and check out some of the science colloquia we have going on as well, and MJC Giving Day if you can. That would be fantastic. And thank you very much. I guess people can virtually clap in the chat. We see some thank yous coming in into the chat. So we'll have some virtual applause for you. Thank you so much, Chelsey.
Yeah, thank you for the opportunity to speak today. I appreciate it. And thank you for helping me work through my internet issues. I appreciate that as well.
Okay. I think we've all been there.
Thank you all.